bones would break. I'm so into you. I'm so into you.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
Welcome to the Inside the Boards podcast. I am Patrick Beeman, your usual host. Today's episode, though, is part one of an interview that Chase DeMarco, who hosts the medical Mnemonist podcast, that's Mnemonist, spelled like mnemonics, focused on study hacks and accelerated learning techniques. He's actually hosting this episode and going to become one of the usual hosts of the Inside the Boards podcast. You can check out his new podcast, The Medical Mnemonist, by clicking the link in the show notes or searching Medical Mnemonist on your favorite podcatchers. We just got back from AMSA's 2019 convention, had a chance to go out and meet some students, meet some other companies in the space, and it was a really good time. We're going to feature here a clip from a mini interview that Elizabeth did with one of these students we met at AMSA. We want to thank AMSA for allowing us to get out there, meet students, record some live content, and thank Elsevier, who provided us some books, Step 2 Secrets and Crush Step 1, for a giveaway that we handed out. You can check out our Instagram and other social profiles. Twitter's at Boards Insider, Instagram and Facebook at Inside the Boards, just to see kind of what we did and, comment, follow us. We got out there, had some great conversations, and hope next year that we'll be able to see you there as well. News on our audio Qbank. All right, so finally, and actually I had a student come up and say, hey, you've been saying this audio Qbank app is going to come out for like months and months, and I was sheepishly in agreement because it's true, but listen to this. We actually have submitted the iOS beta app to Apple's App Store. And I guess per usual, this sort of thing, you submit and they come back and say, hey, you need to tweak this or change that. And we've done a few rounds of that over the past week, but literally any day our iOS beta app will actually and truly be out. For those of you who have already subscribed, thank you so much. It supports us. It helped us actually go to AMSA, for instance. It helps us continue the work on this podcast and to provide high yield, free MedEd for you. For those who have not yet subscribed, our all audio Qbank is one of a kind. We feature audio optimized questions in step 1, thanks to Exam Circle and Lecturio. And for step 2, thanks to Online MedEd. You can learn on the go while you're driving, exercising, doing the dishes, whatever you have to do in life. We hope by releasing this product and continuing to think of ways to create other products that we will help you save time and redeem some of it so that you have the ability to do other things in life, like spend time with your family, exercise without guilt, just kind of the stuff to have a well-balanced life so that your career and life in medicine will continue and you will be fulfilled throughout it rather than frustrated and burnt out. I know it's not like the one solution, but it's a solution that we can, or we hope, can help you. Right now, go to InsideTheBoards.com if you haven't subscribed. Take the leap, please support us. As well as now, you can get introductory pricing on the All Audio Qbank. Click the link in the show notes or go to InsideTheBoards.podbean.com. Anyone who signs up will get double the length of their subscription access at a much lower price. But this is going to go away like literally any day. We're going to be closing down that channel, phasing it out. But it's pretty cheap. 1 month, $15, 3 months, 30, 6 months, 50, 1 year, 100. Sign up, take advantage of it, but do so ASAP because we'll be phasing it out. You can go to InsideTheBoards.com, sign up for our email list, and we will be sending you some premium discounts on various MedEd partners that we've connected with, as well as notify you of when the iOS beta app does launch. and keep you updated for the full-scale version of our app, which I hesitate to make predictions given my track record, but it's looking like it's on track for an end of May release. So sign up for our email list to stay updated. Here's a little segment from AMSA and then Chase's interview. Thanks for listening. Tell your friends. Check out the Study Smarter series for Step 2 and Step 1 that'll be launching on the Study Smarter podcast. We find it a pleasure and a joy to serve you and your educational needs, and are so honored that you take the time to listen to us and support us. So rock on, study hard. Here's the real part of today's show.
Welcome back, Boards Insiders. We have Joshua Wilms with us, and we're at the AMSA 2019 convention in Washington, D.C. Joshua is a third-year student at Texas Tech University. He's an MD PhD student, so he has a lot going on, and he's already taken Step 1. And he's been through the entire AMSA conference, so he has lots of things to talk about. Our first question for Joshua today is, how do you balance doing an MD and a PhD? That's a lot.
Well, so you don't do both of them at the same time. Otherwise,
Okay.
I mean, that would be impossible for me.
Okay.
I mean, to anybody who is an MD PhD getting started, when I started out, I tried to do research for part of my first year. That was a bad idea. When you're in med school, I really think you should just focus on medical school. That is more than enough. If you have extra time, take a nap or,
Yep.
Go on a walk, take a break instead of on top of medical school, trying to study, getting ready for board exams and be like, oh, I'm going to continue with like a little bit of pre-med syndrome and try to, get as many gold stars as I can by doing some bonus research. I think that's just the recipe for not being able to do well on either. Yeah.
Okay.
So I would say just do medical school during your medical school years, research during the summer, and then do your PhD during your PhD years.
Fair enough. Now, what's the benefit of doing the MD PhD program for you? What kind of made you do that?
Well, it impresses the ladies. So I want to do research on Alzheimer's long term. And my odds of being able to contribute meaningfully to that field increases if I have both a medical background and rigorous training and research. So, I could do research on Alzheimer's as a PhD or as an MD, but if I do both, I just feel that I'll have the most training and the most potential for making a difference in that field.
That's awesome. Okay, so you could really research is your big focus, though.
Yeah.
All right. So, do you feel like the medical side of things? I mean, is it still interesting to you? Are you still thinking as a clinical are you going to do some kind of clinical practice, or does this feel like a checkbox?
Yes. So I'll definitely do a little bit of clinical practice, but I'll primarily focus on research because I want to focus on Alzheimer's and neurodegenerative diseases. Right now, there isn't that much that I could do in the clinic. There are a few medications that can delay symptoms, can provide some symptomatic relief, but ultimately if somebody gets Alzheimer's right now, at some point the medication isn't going to be able to help anymore, and it's just going to be a slow downhill trend for them. So really, to be a clinician who wants to help patients with Alzheimer's means that I need to do research to find out how to help them.
Okay, so you really do want to do both.
Yes.
You do. Okay. And tell me about your study habits. Like, you've already taken Step 1. You don't have to tell me anything about how it went, but tell me how you studied for it.
So I used the standard research material. Texas Tech is really nice in that they buy us a lot of those materials and give them to us free of charge.
Okay.
But so, I use first aid, sketchy, Anki, delayed repetition flashcards. Any medical student should probably know about Anki and be using it.
All right. Oh, Brosencephalon?
Yeah.
Oh, I know
Yep.
Brosencephalon.
Yeah,
I don't think that was a thing, though, when I was in med school.
Yeah, I use Bros deck. There are a lot of other good decks out there, too.
So first aid and
Yeah. So
New World, obviously.
Yeah, of course. All the Pathoma, all the classic stuff.
Inside the boards now.
Yeah.
No.
So I studied hard and spent a lot of time studying. But apart from that, I made sure I got sleep because sleep is essential for remembering things.
What's the minimum? What do you think your minimum is you got to get?
Okay, I would get 7 or 8 hours of sleep a night. And I don't think that sleep is ever wasted time. Because the days when over the long term, first year of medical school, I did not get enough sleep.
Okay.
I pulled all-nighters regularly before exams, and that would sort of short-term help me on that exam. But then long-term, I forgot much of that material. And med school isn't about short-term doing well on individual exams. It's about long-term improving a whole body of knowledge so that whenever you're studying, you retain it long-term, and then all of that builds up on itself and really helps you when it comes to, say, step 1.
Right, and then eventually clinical practice, hopefully, right? Hopefully some of it.
Oh, yeah. And of
Some
course,
of it.
clinical practice. I don't know.
That's so far down the road.
Yeah.
So, all right, fair enough. So for the sleeping the night before the exam, what you're saying is even if you feel like a couple hours I could cram some more stuff in, the sleep itself is more beneficial for you to be able to perform well the next day.
Yes.
Okay. And how exhausted were you after step 1?
I was so exhausted.
What did you do?
Oh, my goodness. I played a lot of video games. I took my dogs on walks. I went to the beach. In my room, there was a noisemaker, though, where it was like ocean waves coming in and out. And I had that it was on for a couple of sections and actually really annoying. But then so when I got to the beach and I was trying to relax out on a balcony and I heard the waves coming in and out, I just got so triggered and it brought me back to step 1. I was like, oh no!
You had a little step 1 PTSD?
Yeah. So now the beach has been ruined for me.
Oh, God. That should be a question on the interview. What's the best thing that medical school ruined for you already?
Oh, my gosh. Well, okay, I mean, there's the beach. I don't know. I mean, coffee.
Coffee.
I used to really enjoy coffee, and now I maybe it's because I transitioned to just drinking black coffee, and then it would get cold, and then I just drink the cold black coffee. Not ice cold, lukewarm.
So now it's gross.
Yeah, so now maybe part of that's just because I was drinking it functionally.
What do you think is a study habit or a study tip that would be something that makes you study differently? Like our little theme, study different. Do you have any kind of quirky habits or anything you do?
I would go on walks with my dogs while doing Anki. So that would keep me awake. My dogs would see a squirrel and pull me a little bit. So whenever I got tired or maybe later in the day when I wasn't focusing so well, I would get my Anki deck and I would turn on the voice function so that it would read the flashcards to me. And then I would go do something active, whether that was walking on a treadmill, walking outside, getting on a stationary bike.
Okay.
So the times when I wanted to keep studying, but it felt like if I sat at my desk, I would maybe fall asleep or I would daydream.
Yeah.
Then I would do something active.
That's a great study advice. That's the whole philosophy why we made Inside the Boards this audio question bank is because we know people are, you can only do so much of sitting at your desk or, kind of melting into the couch reading a book. All right, that's awesome.
And then I also made, so there's no sketchy memory palaces for biochemistry yet.
Okay.
So I actually mapped out the majority of biochemistry from first aid in a set of memory palaces.
Wait, do you have them written down?
I have maybe half of them on YouTube, and then the other ones I have in my notes, and I haven't made videos on yet.
Where can people find those on YouTube?
It's Forget Me Not Biochemistry.
Forget Me Not Biochemistry?
Yeah.
All right.
I've got 3 or 4 videos on there. It's a tiny one.
Okay, but that sounds awesome. If it's something we can't get anywhere else.
But biochemistry was one of the hardest things for me to learn, so I really focused on that when I was studying for step 1, and that ended up being one of my best subjects.
Okay.
Really easy to remember just because I had these memory palaces.
Good. All right, well, thank you. That's a great tip for our listeners. Anything else that you would like to give as a closing piece of advice for people in medical school or people considering an MD, PhD program?
First off, focus on your relationships with other people. School matters, getting gold stars on your resume matters, matching into a good residency matters, But what matters a lot more than that is maintaining good relationships with the people in your life, whether that's your boyfriend, your girlfriend, your mom, your dad, brothers, sisters. Those are the things that most people find out that are what matters to them the most in the long run. And then those are also the things that end up allowing you to do well.
Okay. I think that's excellent advice for wellness and just having a well-rounded, well-balanced life. All right. Well, thank you for being on the podcast.
If you have questions about research statistics, medical society guidelines, or the ins and outs of clinical trials and drug safety, stay tuned for a great interview. But first, here's something from our all-new Step 2 audio Qbank, powered by Online MedEd. Alexa, teach me family medicine.
A hospital researcher wants to validate her screening test for HIV. She tests it on a group of 1,000 prisoners with a known HIV prevalence of 10%. She performs the same screening test on a group of 1,000 undergraduates with a known HIV prevalence of 2%. Which of the following is true of the screening test characteristics? Is it A? The negative predictive value will be higher in the group of undergraduates compared to the group of prisoners. B? The positive predictive value will be higher in the group of undergraduates compared to the group of prisoners. C? The sensitivity of the HIV screening test will be lower in the group of undergraduates compared to the group of prisoners. Or is it answer choice D? The specificity of the HIV screening test will be higher in the group of undergraduates compared to the group of prisoners. And the correct answer is choice A. The negative predictive value will be higher in the group of undergraduates. Sensitivity and specificity are intrinsic properties of a screening test. In other words, the sensitivity and specificity of a test will be the same, regardless of the group it is used on. However, the positive and negative predictive values are dependent on the disease prevalence. In other words, the same test can have different positive and negative predictive values based on the disease prevalence in a group. Building the 2x2 tables will bring you to the same conclusion. Remembering these characteristics of screening tests will save you time on the test. And just as a reminder, positive predictive value is the probability of disease in a patient with a positive test result. Prevalence and PPV are directly related. If one goes up, so does the other. Negative predictive value is the probability of no disease in a patient with a negative test result. Prevalence and NPV are inversely related. If one goes up, the other goes down. In the question, undergraduates have lower prevalence, therefore a lower PPV and a higher NPV.
On today's show, we will cover evidence-based medicine and medical myths with Dr. James McCormack. Dr. McCormack is a PharmD, professor at the University of British Columbia, and the host of the BS or Best Science Medicine podcast, which has been a long-running science and medicine podcast running since about 2008. He's also the publisher of dozens of books, papers, and lectures on the topics of medicine and medical research. Dr. McCormack, how are you doing today?
Good, thank you. Thanks for inviting me. It's always a pleasure to just chat with pretty much anyone who listens to the concepts of evidence and healthcare and trying to put it into context.
No, this is perfect. There are so many misconceptions about what the evidence says. What is the difference between an RCT versus medical society guidelines, and clarifying these for the students and any other listeners would be very, very helpful.
Yeah, so as you were mentioning, so some of the stuff that I try to do, and I've been doing this for a long, long time, is how do we get, I guess, any healthcare provider, and in fact, any healthcare provider or any patient, which is pretty much everybody in the world, how can we get them to be more, or to have a better appreciation for evidence and put it into the context? And so, as you mentioned, I do a weekly podcast and we publish lots of different papers, and as much as possible, trying to get people to think about what to do with the evidence. Because as you know, as I've looked at it, and maybe I'm happy to have you talk about it, there's a lot of BS out there. And how do we figure out what is, real BS and what's not BS and that sort of stuff? And, a lot of stuff that I focus on is just the concepts of evidence-based practice And even though a lot of people can, there are people who say that they have problems with things like evidence-based practice or evidence-based medicine, I think it provides a proper approach to think about things. And I actually don't know how people can argue against it. I mean, certainly when you talk to patients and you go, do you think we should use the best available evidence? Most people say, yeah, I assumed you were already doing that.
But that's not always the case, we seem to find out.
Well, no, and so that's where it gets tricky. And I think it may be worth, if we're going to talk about evidence and evidence-based practice, I think we have to have a common definition so that you and I are both talking about the same thing. I mean, so I think the definition that most people use, and I think it works very, very well, is that, it is using the best available evidence. And the best available evidence may be none. And I think it's incredibly powerful when we know there is not much evidence at all. That's a very powerful thing to know, because then it opens up all opportunities to say, there's a lot of flexibility in it. But so you need to know the best available evidence, and that could be RCTs. It doesn't have to be RCTs. In fact, many questions in medicine are not answered with RCTs. You need cohort trials. And certainly, there is not going to be a single study of you, right? Unlikely, anyway. So, so the best evidence that a drug works for you is an N of 1 trial. And so there's all sorts of different levels of evidence that we have to consider. And then when we have the best available evidence, we then incorporate it with clinical experience or clinical expertise, if you will, which is really important. A great example where knowing the best available evidence isn't that useful. For instance, if you wanted to, let's say you needed a hip replacement. There's not a ton of evidence around that. Like I'm not aware of any RCTs around hip replacement. But what you really want is someone who's really good at it. So you want a technician, if you will, who's very good at doing that surgery. So whether or not there's no doubt. I mean, all you need is an N of. You only need to do one hip replacement to realize that if you take out a hip that's really, really painful and is, completely destroyed by osteoarthritis, it gets better. Now, you can have complications and all that sort of stuff. But in that case, we're not necessarily looking at evidence. What we're trying to do is, find some information in regards to a person who's very good at it. And then the other aspect of evidence-based practice is, and it's a big thing that I like to talk about, because in my experience, guidelines are remiss in talking about it, is the concepts of values and preferences, patients' values and preferences. When we look at, if we talk about, statins or blood pressures or glucose medications, let's assume they reduce the chance of heart attacks by 1 or 2 or 3 or 4% absolute numbers. Well, that means the vast majority of people don't benefit. So we need to then have the patient chime in and say, I need to know that evidence, and I need to incorporate that into whether or not I want to take a drug, whether I want to be monitored, the cost, the side effects, and all that sort of stuff. So that's the premise that I come from on a hopefully a fairly regular basis to talk about evidence-based practice. And so one of the key things that we do is look for and create hopefully useful synopses of evidence, because probably 20 or 30 years ago when this first concept came out, everyone said, well, what we want to do is we want to make sure everyone can do critical appraisal. And that was an unmitigated disaster, relatively speaking, because it takes a lot of work. I mean, as I'm sure you know.
So something that you mentioned was an N of 1 trial. For the audience, can you explain that topic a little bit more?
Yeah. So let's say you have a migraine, and let's say I have a study that says acetaminophen is more effective than placebo for migraine. Then if I give you acetaminophen and your migraine doesn't go away, I can't go, well, it did, because there's a study showing that it works. So an N of 1 is, we may have evidence that it works in a population on average, but the only possible way to figure out if it works in an individual is to have you try it. And, so you can do an N of 1, at least acutely, but more often than not, N of 1 trials are done for people with chronic conditions, where you randomize them over time to either on the drug, off the drug, on the drug, off the drug, or on the drug, placebo, or on the drug, and see if you can then show that when they are on that medication, they are better, because that's ultimately the sort of, and in fact, it's actually one of the highest levels, if not the highest level of evidence, is if it works in you above and beyond what placebo does, then it's effective. So yeah, that's sort of what an N of 1, and they can be blinded, or they can be unblinded, depending on whether or not you can blind the intervention.
Okay, and that sounds kind of like blanking on the term right now. Individualized healthcare, individualized treatment plans.
Well, sort of, yeah. And there's another thing that there's a lot of BS around is personalized medicine, but personalized medicine, has been, that term has been sort of taken away. In my mind, personalized medicine is exactly that, what we just talked about. But personalized medicine is often being taken up by the genomics people to say what we can do is we can do genetic testing and figure out what medication would work for you and which one wouldn't, and on all that sort of stuff. Even though it's a really, really cool area of practice, and there's a few, and I mean very few examples where knowing that aspect of personalized medicine is useful. I still think decades away from it being that useful. So when people talk about personalized medicine, I think I'm agreeing with you, is to say personalized medicine is how do you figure out if it's working for a particular patient? Because that's sort of the art, if you will, of medicine, and what we really need to focus on, because boy, we have a lot of people on a lot of medications. Some of them are great and useful, but boy, a lot of them are not.
I noticed on the YouTube video that is on your page, Bohemian Polypharmacy. It was really, really fun, really interesting, but there's some stats on there that I had no idea about, that really the number of multiple medications that some patients are on and the effectiveness of some of them just doesn't seem as strong as I was led to believe previously.
Yeah, and that's we see that in all sorts of training, is that you guys get trained to that hypertension is bad, therefore it must be treated. High glucose is bad, therefore it must be treated, and you make the assumption that clearly the evidence must be overwhelming that treating these things is effective. And so it depends on how you define evidence, and it depends on the magnitude of it. And even in the terms, even polypharmacy is a bit of a misleading term, to tell you the truth, because if I said polypharmacy, that comes across with sort of a negative spin, I would imagine, to you.
Mm-hmm. It does.
Yeah, and it sort of is meant to be that way, but it doesn't have to be, because you could have polypharmacy. You could be on 5 medications, and they are the exact drugs you're supposed to be on. They are the exact dose and everything, and there's nothing wrong with it. And so I've been working with a group recently, and we've been talking about, instead of using that term, maybe talk about medication overload, like being on ones that you definitely don't need, or the dose is wrong, or if you're on 8 or 9, maybe they're interacting with each other, and maybe we can't figure out which one is working. So yeah, I think the approach that I've always suggested with people, if you see people on a lot of medications, the best way to look at it is to go, and this is not to be a therapeutic nihilist, but to assume that the patient doesn't need to be on the drug, or that the dose is wrong. If you go in with that attitude and try to prove otherwise, you will find that a lot of medications are not needed. You might even find some medications that are needed, or the dose is wrong. And I think if one does that and has that focus, if you want to be more often right in medicine than wrong, which I hope we do, go in with that approach, because the evidence is overwhelming that people are on many medications, often at the wrong dose, and they're not having the effect that they would have believed that they believe that they would take them for.
So it seems like this starts really early. This begins in medical school, where our board exams, for instance, are based on medical society guidelines. And that's just how we absorb the information at first. But possibly some of those are wrong. Is it an institutionalized problem? What's some of the backlash maybe you've received from having some of these views from others in the field?
Well, yeah, and I always find it fascinating that you do get backlash on it. That there's a backlash, that the concept that you should use the best available evidence, you should use your clinical expertise, and you should use patients' values and preferences. It shocks me that should not be the case. But no, you're right. So, and in fact, I was in at a conference in Copenhagen in August, and we actually had a forum, if you will, set up by two medical students from Copenhagen. And the question they asked had to do with, how much evidence appraisal, if you will. And like I said, I'm not even a big fan of that concept of evidence appraisal, but how much evidence should we be getting our students to look at? And they didn't get, they were quite honest. They said, we did not get much evidence assessment or evidence even how to look at it in their program. And there is a debate, and I don't even know if there's even an answer to this debate. But what do you do? Do you right up front? Do you put in healthy skepticism into a first year medical student or nursing student or pharmacy student, or do you first of all get them to look at understand some of the concepts, learn some of the guidelines, and then tell them, we were kind of kidding. Those guidelines may not be perfectly evidence-based. And I don't have a great answer. I personally think it should be a blend, because the role for guidelines, most guidelines, if you follow them, you will not end up killing everyone.
Hopefully.
That's a good thing. Yeah, and you'll help some, but you will do potentially a lot of harm and inappropriateness if you follow them to the exclusion of all the other principles around evidence-based practice. So, the best person to answer any of those questions would be to talk to someone like yourself or people who are students to go, well, what would you rather have? Would you rather just have us tell you what to do and then you just do it? Or do you want us to help you understand how we answer questions and how science and evidence evolves, realizing that you may not have time to do all this, and often you just want to know what to do. So I don't have a great answer for it, other than I think it's a blend.
Yeah, I think definitely right now we have more of the first situation where we're just kind of taught this is what to remember, this is how it works, implement this rule, and not really how to critically assess the research. I still have problems myself when someone sends up let's say there's an online disagreement and they post this research that proves their points, and I know that that's not accurate, but how to step by step go through it and pick apart which parts are being skewed to some way to get that confirmation bias. It's tricky.
Oh, it's very tricky. And so one of the things that we try to get our students in our programs to do is identify sources of people who are trustworthy. Do these evidence synopses. We do, at least in the program, in the Faculty of Pharmacy and a little bit in the Faculty of Medicine here, we do train a number of our students to know how to do, if you give them an RCT, how to evidence appraise it, how to look at it, look for sources of bias, how to put a synopsis together, and so on and so forth. And we do that with the total understanding that may not be done they're not going to do that every day in practice, but they at least have to have they have to know what goes on behind the curtain. Not perfectly, but enough that they can then converse in those issues. And then most importantly, I think if a person is practicing on a regular basis, you're not going to have time to go to, the primary literature for everything. But if you know how to look at a Cochrane review, if you know how to find that sort of evidence and how to look at it, that's a huge step above just following a guideline. And you need to identify sources like the Cochrane Library, which, is it perfect? Absolutely not. Is the stuff that we produce perfect? Not in a million years is it perfect. And nothing is perfect. But it's, people attempting to get the best available evidence. And then what I try and encourage in healthcare providers, whatever area you are in, you're probably on a day-to-day basis doing 10, 15, 20 things every day. In primary care, it's going to be different than if you're a cardiologist, and so on. But if you're going to be, especially when you're involving patient care, you at least better have a reasonable synopsis or a reasonable idea about what the best available evidence says. And not does it work or does it not work, but how big of an effect is it and how sure are we about it? And so to do that for the top 10 or 20 things in your practice doesn't take a lot of time. I can almost guarantee you that every one of those questions is someone who you could probably trust has done a review of that. You just need to know how to look at it and how to interpret it.
And if you're not taught how to critically appraise these in medical school, you might lose that ability, because once you go into residency, have your own practice, you're very busy. You don't necessarily know how or want to spend the time to learn this as effectively as you would have if you'd been implementing the steps ahead of time, I'm assuming. So I would agree that's probably a very important thing for schools to concentrate on more, is how to critically appraise these trials.
Yeah, no, I agree. Now, that it's tricky, because what it does is it sets up a lot of cognitive dissonance. And by that, what I mean is, yes, I know you just had an endocrinologist come in and say, these are the drugs that we use for diabetes. This is the first one. This is the second one, and the third one. And then when you look at the evidence, you go, yeah, but we're now studying, there's a number of studies showing that these medications don't reduce any important endpoints. So then that's a struggle. There are clearly studies that show that some of them do reduce important clinical endpoints. Yet almost very rarely is that information given to you guys. And really, we just want you guys to have a healthy level of skepticism. We don't want to make people cynical because that's just boring. But yeah, we just want you to be skeptical. Just go, I wonder if what you just told me is true. And that applies to everything I'm just saying right now. It's not just, it's not like I'm coming from, the mountaintop and saying this is the way to do it. Be skeptical about everything that I'm saying. But at some point you've got to identify people who you can build trust in to say, you know what, their agenda is not, it's not to get people on medications. It's not to get them off medications. It's just to go, what do we know about it? And then once we have the best available evidence, all the rest of it is the skills set that we learn over time as we become, for lack of a better word, clinical experts in what we do.
And science is supposed to be met with healthy skepticism while not falling into the trap of being a contrarian. So that seems like it's how things should be, but we don't always see that.
No, and people take it personally. I've given up on taking things personally. Like, if people get heated about whether or not a patient should take a statin or not, they've lost it. Because there's very few things that work in everybody. I would, and we're not talking about emergency treatments we're primarily talking about chronic treatments in this sort of stuff where they're not life threatening. But for instance, I mean, the one class of agents that I talk about on a regular basis that really work in virtually everybody is something like either local or general anesthesia. So it pretty much works for everybody. Now, but as I'm sure you're probably aware, there are people who will go to the dentist and not want local anesthetics. Mm-hmm. I think they're nuts. But, maybe they had an allergic reaction to it. They don't like needles, or they have a very high pain tolerance. And that's great. But that's a drug for which it's 100% effective. And I would make sure that people realize that it's going to be very uncomfortable and that they can always change their mind. But so even for a drug that's that effective, you still have to go, it's your decision within reason. Obviously, if someone says, yeah, I'm going to have a heart transplant and I don't want general anesthesia, that sort of person we're going to have a chat with because, there's no possible way you can do it without general anesthesia. But when it comes to, all of these other things, I think it's, and especially because most of the time we're not, even the best available evidence doesn't suggest by any stretch of imagination that it works in everyone. For instance, a reasonable number to use, and I'm happy to sort of tell you where it came from, is if we treat everybody for all of the risk factors that we're talking about, blood pressure, cholesterol, and glucose and those sorts of things, even if we didn't look critically at the evidence, we're still talking at least 60 to 70% of people over a lifetime never get any benefit from treating those things. So that's the issue that we need to focus on, because we can only reduce risk by so much. And for you to have a benefit, you would have had to have had that event, because preventing something that was never going to happen is not a benefit.
So would maybe for the number needed to treat, I know there's a website, the nnt.com, I think it is. Would something like that be, or are you aware of that or another resource that's a very trusted resource for these types of numbers and statistics for the students to go check out?
Oh, yeah, for sure. And in fact, I'm part of it, the NNT, that website. So I'm involved in editing some of those things. And yeah, it's one of a number of very many useful websites. The problem I have, not with the NNT, the website, but the concept of an NNT, is that an NNT doesn't give you all the information you need to have a discussion. So the NNT just tells you, the numbers of people that need to be treated to benefit one. And often there's actually some reasonable evidence that it's a poor way to describe evidence to patients. And by poor, I mean, it's not as useful as just doing other ways of doing it. Because if I told you the NNT is numbers needed to treat is 10. That means it's a 10% absolute benefit. But you have no idea whether the risk goes from 10 down to 0, 20 down to 10, 30 down to 20, or any of those sorts of things. So while it's useful to know the NNT, and we've sort of put it into our sort of lexicon, if you will, I think a way better way of doing it is if you know, if I did nothing, what's the chance of something happening? And that could be the chance of heart attacks or strokes, or it could be the chance of your strep throat getting better, or the chance of your bladder infection getting better. And then if I treat, what does that change? So if you know the numbers of, if I didn't treat, what would it be? And if I did treat, you don't need anything else. That incorporates absolute numbers, and you could figure out relative numbers and numbers needed to treat. And I think it's a useful discussion to go, if we didn't treat, your chance of having a heart attack or stroke in the next 10 years is 10%. And if we treat, it goes down to 8%. Now, there are definitely people who don't even get that. So you have to sort of, show the happy face icons, people that have seen, or maybe bar graphs and all that sort of stuff to help them understand that. But that's all about trying to assess, just like, I don't know if you've had any experience, but if you try to explain, here's how you use an inhaler to a patient, you could be the perfect person in showing them how to use an inhaler. And then you ask them to do it and they don't even get it close.
Yes, I've had to explain that many times.
So there's a big difference between teaching someone something and then having them actually learn it. I mean, there was a great cartoon. I remember the guy, there was a dog sitting next to him and a person who he was talking to, and it says, I taught my dog to speak. And the person is looking at him going, like, within incredulity, whatever the word is. And he says, well, I taught him. I didn't say he learned it.
So it sounds like nothing's 100% and everything in context.
Yeah, I think so. Yeah. And everything into the context of the best available evidence, clinical experience or expertise, and patients' values and preferences. And as much as possible, it's impossible not to, have an emotional connection to all this. But I mean, I know people who get clinicians who are just frustrated or annoyed at their patients if they don't take warfarin, when they've said, I think it's best if you do. And that it should not be a source of frustration. They should be frustrated if they've not been able to get the patient to make a shared decision. And we recently wrote a paper, myself and Glenn Elwin, in EMJ, EBM or EB practice, I think, evidence-based medicine, I think. And the issue that we came up with is the only outcome that we should care about for the vast majority of things is that a shared decision was made. Now, we were being provocative to some degree, but not that much. I mean, if you've had a shared decision, just here's an example. When you write a prescription, and this is ballpark numbers, and 30% of the prescriptions that get written don't even get to a pharmacy.
Wow, that's pretty high. I would have had no idea it was that high.
Yeah, and it clearly depends on what area we're talking about, and sometimes it's appropriate. Sometimes it might be, here's a prescription for an antibiotic. I'm not sure if you need it, but if you do, fill it. Those sorts of things. But and it doesn't matter whether it's 20% don't get there or 30%, but it's around that. And then then of the people who fill a prescription, probably half of them are not going to be are going to have varying degrees of adherence. So that everybody is putting in their values and preferences. But as clinicians, I don't think we appreciate the nuances of that. And we give terms that you're not compliant, as if you're just, we're going to give you the paternalistic view of, Mrs. Jones, you really should be compliant with this. It's very important. But she doesn't like taking it. It upsets her stomach. It costs too much. There's too much monitoring. It affects her life too much. And so Victor Montori, who's come up to we have a course here in Vancouver every year, and he came up and spoke 4 or 5 years ago, and he's got a concept called minimally disruptive medicine. How do you do good quality medicine and not irritate the hell out of everybody? And it's a great idea. It's not the term is tricky, minimally disruptive medicine, but I think it speaks to what it is trying to do. Is very few people literally go, it's going to be a good thing today. I'm going to the doctor. Or I'm going to go wait in line at a pharmacy to get my medications. Very few people go, now that's a high quality experience.
Good point.
And once more, thanks to the band Knights. That's Knights with 2 I's. and Sun Pedal Recordings for letting us use the song So Into You off Night's newly released album, Hellebores Part 1. You can check them out wherever you stream music, or click the link in the show notes to hear more on Spotify.
If you were the darkness, what do I make of this feeling so light? I'm so